At ESTRO, I will talk about the quality assurance of radiotherapy that we have done within the International Randomized Breast Cancer Trial, SENOMAC. And maybe I should start by telling you a bit about SENOMAC, what it is. We know that axillary treatment in breast cancer today often includes the sentinel node biopsy. And here, the sentinel node is the lymph nodes to which the breast cancer first spreads. And we know that if the node doesn't contain cancer cells, it's safe to refrain from further axillary surgery. But there are indications that a full axillary lymph node dissection may neither be necessary in patients with limited sentinel node metastasis. And here we have the AMAROS trial and the SED011 trial. But this is further investigated in the SENOMAC trial. And patients with 1 to 2 macrometastases in the sentinel node are randomized to a full axillary lymph node dissection or no further axillary surgery. And the study allows both T1 to T3 tumors and both breast-conserving surgery and mastectomy patients. And mastectomy patients weren't allowed in the SED011 trial, so here we'll have new data. And in SENOMAC, local regional radiotherapy is given in both study arms according to local guidelines. And we know that radiotherapy, as well as surgery, affects risk of recurrence and side effects such as arm function and lymphedema. Since radiotherapy within the trial is given according to local guidelines, this varies to some extent between participating sites and countries. So a detailed description of the radiotherapy given is important in order to make sure that this doesn't risk affecting the main trial outcomes, which are recurrences and quality of life in relation to surgical technique. So this is what we have done. We have made quality assurance of the radiotherapy given within the trial with focus then on possible differences between study arms, which could bias the trial results. What we did was that we reviewed RT plans from Swedish and Danish patients. And this is because these two countries have included 94% of the patients included in SENOMAC, and reviewed all RT plans for patients included before June 2019. And we were able to retrieve 96% of the RT plans for Swedish patients and the 91% of the RT plans for Danish patients. In both countries, guidelines recommended treatment to level 2 to 4. There were slight differences in inclusion of internal memory nodes, but the big difference lies within inclusion of level 1 in the CTV, and level 1 is the most lateral part of the axilla, closest to the humeral head. And in Sweden, the decision to include level 1 was site-dependent, with the instruction that RT planning was not allowed to differ between study arms. While in Denmark, on the other hand, radiation to level 1 was advocated for patients with less than 10 lymph nodes removed, but not in those having a full axillary lymph node dissection. So in Denmark, the recommendation was to include level 1 in the target volume for patients that had a sentinel node biopsy only, but not in those having a full axillary lymph node dissection. So this indicated the difference between between study arms. And so then we made possible differences in target volumes with a focus on level 1 and its possible implication on study results, recurrences, and quality of life, the main focus of the RTQA. And for Swedish patients, we then reviewed all RT plans and dictamized the CTV as including level 1 or not. For Danish patients, we had this information already in the original CTV. And we found that for Swedish patients, there was no difference in inclusion of level 1 between study arms, while for Danish patients, on the other hand, most patients in the sentinel node only arm had level 1 included in the CTV, but not in those having a full axillary lymph node dissection. So indeed, there was a difference in target volumes between treatment arms. But we know that due to the tangential field technique that is most often used in breast cancer surgery, in breast cancer radiotherapy today, level 1 receives a considerable dose, even if not included in the clinical target volume. And what we found when looking more thoroughly into the individual doses to different lymph node levels was that if included in the target volume, the V90 to level 1 was almost 100% and the D90 about 95% of a prescribed dose. But even when it was not included in the CTV, the B90 was about 80 to 85% and the medium D90 about 70 to 75%. So even if level 1 was not included in the CTV, it still received a considerable dose from the adjacent fields from the other lymph node stations and the remaining breast or thoracic wall. We also looked at dose to the humeral head. And here we could see that there seemed to be a difference if level 1 was included, then you had a higher dose also to the humeral head. But the interquartile range was quite large and it was a large difference between clinics. But since the sentinel node only arm more often had level 1 included, this indicates that a higher dose may have been given to a humeral head in this arm than in the other arm. However, this is also the arm where we expect reduced side effects due to less surgery. So if anything, this may diminish the positive effects of less surgery, but not bias the results in favor of intervention, which is then sentinel node biopsy only. So the conclusions that we did was that indeed for Swedish patients, there was no difference in target volumes between treatment arms. Radiotherapy was given in a similar way, regardless if the patients had a full axillary lymph node dissection or a sentinel node biopsy only. But for Danish patients, there was a difference in target volumes, where patients with a sentinel node biopsy only had level 1 included in the CTME, but not in those with more surgery. However, we found that even when not included in the CTV, level 1 still received a considerable dose. So this difference in radiotherapy should not affect the main trial outcomes, which is recurrences in relation to surgical technique.